So your baby was born with a blocked tear duct and you've been doing the massage just as instructed, but now the ophthalmologist says your baby needs surgery. What does that mean? If you're interested in finding out, keep watching. I am Dr. Rupa Wong, board-certified pediatric ophthalmologist, and on this channel we talk about eye health, kids' eyes, and eye surgery. And today is a topic near and dear to my heart because we're talking about nasolacrimal duct obstructions, also known as blocked tear ducts. In addition to being a pediatric ophthalmologist, I'm also a mom to 3 kids, and all 3 of my children had this condition. I swear it's got to be like a thing, right? Children of the pediatric ophthalmologist have the eye problem. And so what you've likely experienced is your baby was born, so cute and so sweet, and a lot of gunk in the eye, a lot of tearing, and you've been doing the massage as instructed 3 times a day. The good news is that this is a really common condition. Congenital nasolacrimal duct obstructions affect 5% of newborns. And the even better news is that 90% of the time, these obstructions open up on their own without any need for surgical intervention. Massage alone or antibiotic drops or even breast milk is sufficient. But you might be watching this because you're at the stage where your ophthalmologist has told you that surgery is required. And that sounds really scary. That's part of the reason that we don't do any surgery before 12 months of age, because if 90% open up by the time a baby's 1 year old, why put a baby through general anesthesia and an unnecessary surgical procedure? But the percentage drops tremendously after 12 months of age. So after 12 months old, then usually these obstructions just do not spontaneously open, and that's why we recommend surgery. All right, so what does surgery require? Well, first of all, it's always done in the operating room under general anesthesia with a pediatric anesthesiologist. That's how I do mine. The surgery itself is very short. It typically takes anywhere from about 5 to 15 minutes. A lot of times they won't even do a full general anesthesia. They might just mask the baby because then the sedation's not quite as deep. That's another reason that we don't do these surgeries until 12 months of age, because the risk of anesthesia is a lot higher for babies under 1 year old versus over. So if we can delay it and it might open up on its own, then that's always a win-win. All right, so what do I do when I'm actually in surgery? Well, first I'm going to always, of course, clean everything with Betadine. Then I use what's called a punctal dilator, and I open up the superior and inferior punctum. The punctum is a little hole in the top and bottom of the inner corner of the eye. So I just open up that little hole, and what that hole does is it connects to the nasolacrimal passageway. The nasolacrimal duct system is what connects your eyes to your nose. So when you are crying, that's why you get a runny nose. In these babies, there's an obstruction right here at the bottom of the nose. So we're trying to open that up surgically. So first I just open up the passageway so that my probes can gain a little bit better entry. Then I use a series of probes, and these are the probes. I'm missing one, but I have these here in the office because this is a procedure we also do for adults. For adults, they can be awake. Children always need to be in the operating room under anesthesia. You see probably these little numbers right there. That tells me the size of the probe. And you can also see how skinny some of them are. Each side is a little bit different diameter. So this top right here is the skinniest probe. That's a 00. Because everything is backwards in medicine. So it's a 00 versus a size 0 right there. And then this one is quite big. This is a size 3. I've never really needed to use a size 3. I typically end with a size 1 or 2 and a size 4. So once I've got the passageway opened up, then I take the skinniest of the probes, the size 00. I insert it into now the dilated punctum. And then I snake my way through the nasolacrimal system, side and down, all the way into the nose. And I know how to check to make sure I'm in the nose. Then I take it out, and then I repeat it by going to the slightly larger size, the size 0. And then I do the same thing with the size 1. And then what we do is we will dye a little bit of saline with a vegetable dye called fluorescein. It makes it a bright yellow. And then I irrigate that system. If I get yellow water coming out of the nose, then I know that the system is patent. Everything is open and I've done my job of opening up that obstruction. If it's not open, then I know I need to go back and probe again. These probes are very thin, they are very bendable, you can see, and they're really smooth. They don't harm your baby. There's very little chance of rupturing or penetrating anything. And it's a really nice, safe, effective way of opening up the passageway. Now, what I also tend to do at the same time as doing the probing and irrigation is I do what's called a balloon catheter. So just like a catheter for, hearts, like an angioplasty, it's a balloon that opens up inside the passageway, not too big. And we do a series of protocols. We open it up for 90 seconds, then we close it. We open it up for 60 seconds, then we close it. We move it back 5 to 10 millimeters and do the same thing. That just makes more room in the nasolacrimal system so that the baby's tears can drain properly into the nose. I prefer doing a balloon catheter dilation instead of putting in actual silicone tubes. The silicone tubes is a clear plastic tube, very bendable, and it'll connect and keep that passageway open. The downside of the actual tubes is that they then have to be removed about 3 to 6 months postoperatively. Your surgeon might prefer silicone tubes, and there's no right or wrong. It's whatever is the preference of the surgeon. Also, I've seen a lot of babies that will use their little finger and grab those tubes, and it does result in a lot of late night phone calls and some increased parent anxiety, though there's really nothing dangerous about the baby just removing the tubes themselves. But for that reason, I like to do the balloon catheter because it opens up the passageway, but there's nothing left behind in the baby's eye. And I just think that that makes everybody a lot happier. So there you go. In a nutshell, that is what probing and irrigation, and that's what tubes are for a blocked tear duct in babies. So be rest assured, it's a really common procedure. As pediatric ophthalmologists do so many of them. It's one of the most common things that we do. It's very safe, it's effective, and hopefully it's something that you can discuss openly with your ophthalmologist and understand why they're doing it and make sure that you are all on the same page. If you have any questions or comments, please drop them below. I'm happy to answer them. I can't provide medical advice, but I'm always happy to educate as best as I can. And make sure to subscribe so that you can be the first to get all of the eye health and eye advice that I am posting regularly. Until next time, I'll see you soon. I'm Dr. Rupa. Bye.